Hello, thank you for spending a little time with us today to talk about the Marfan syndrome. We are three members of the Mayo Clinic's Marfan and Thoracic Aortic Clinic, and we'll each introduce ourselves. I'm Juan Bowen. I'm an internist with an appointment in cardiology as well as internal medicine, and I'm the current director of the clinic. And I've been working with the Marfan syndrome for many years. To my right is Dr. Pochettino.
I'm a cardiovascular surgeon with an interest in aortic disease. I've dealt with the treatment of aortic disease for over 20 years, and Marfan syndrome is clearly one of the diseases that affects the aorta.
Dr. Deyle is to my left.
I am a medical geneticist who has had other training in internal medicine and pediatrics, and I have an interest in connective tissue diseases, which Marfan syndrome is one of them.
So, okay, and you'll have plenty of opportunities to interact with us and ask questions. Remember to put your questions in the chat box. Our learning objectives today are to learn about the Marfan syndrome, define it, talk about current medical and surgical treatment as well. Now, some ABCs or basics. This condition occurs in approximately 1 in 5,000 people. The cause is a mutation in a gene, and Dr. Deyle will tell us a little bit more about what a gene is and what a mutation is. But this is a gene that provides instructions for making a connective tissue protein, which is fibrillin-1. Now, most Marfan cases are inherited, but mutations can also occur as a new development, and some people do not have a family history. Now, in the Marfan syndrome, the entire body has connective tissue, but the most visible changes in the Marfan syndrome are in the eye, in the musculoskeletal system, and in the heart and blood vessels. Now, how was the Marfan syndrome discovered, and what's the history of it? We don't have, it's a fascinating story, and we don't have time for all of it, but I'll just say that Antoine Marfan was a French doctor, and he reported a case in 1896 of a young lady with a certain physical appearance. But it took really many years until science and medicine developed a little further. Dr. Victor McCusick at Johns Hopkins was an early person to recognize that sometimes the body structure meant that you were going to have certain cardiovascular problems. Right around then, pioneering surgeons were learning how to operate on the heart and the aorta, and eventually Dr. Benthal in London learned how to repair the thoracic aorta in a way which we'll hear a little bit more about from Dr. Pochettino, but that was a landmark in the Marfan syndrome. The more modern period has come from investigations into the actual biology, and it turns out that the gene was identified in 1991 by Dr. Hal Dietz and his team. And subsequently, it's been found out that not only is this a structural protein, the fibrillin protein is an important part of connective tissue structure, but it also regulates an important signaling pathway in cells, the TGF-beta pathway. So we are now in the era of science and really understanding what's going on in the tissues. And probably the most important tissue to consider is the aorta. This is a cross-section of the wall of the aorta. And in studying the Marfan syndrome in animal models and also in people, it's important to realize that the function of the aorta is to have a lot of elasticity, and there are important elastic fibers. And fibrillin helps to make up these fibers. And also the muscle cells contract and participate in the function of the aorta. So the aorta is very important. Now, when we go to make a diagnosis, we look for certain external physical changes. We use imaging tests. You'll hear more about genetic testing from Dr. Deyle. And an important resource for all of us is the Marfan Foundation's website, which has all the pertinent information that you need to know, more than we can cover today. So that's a great resource. Now, what about the cardiovascular system? Well, the most dangerous part of having the Marfan syndrome is that you could suffer an aortic emergency, and we need to prevent that. So the first step is identifying the abnormal aorta. We'll show you how to do that. Certain valve changes can happen when both leakage of the aortic valve and leakage of the mitral valve in some people. And farther downstream, the aorta can be affected in a few people, but not in most. We know the normal dimensions of the aorta so that we use our imaging studies, we can recognize when the aorta is enlarged. Similarly, in the eye, we have learned, we use ophthalmologists to examine the eye and recognize the typical change of the dislocated lens that you can see right here. And this is a lens that has lost its support because of weak connective tissue. And when we look at patients with a loss of that lens, we see a certain shakiness in the colored part of the eye that you can see in this patient. So that's part of the recognition of the Marfan syndrome. Now in the heart, we talked about the aortic root, which is the very beginning of the aorta. Right here is a normal aortic root, and on the right is a dilated or aneurysmal aortic root. Now on imaging studies, we're in a wonderful time in medicine where we can do a lot of non-invasive and very accurate imaging. This is an echocardiogram, and I'm showing you right now the first part of the aorta on an echo. And the same way on cross-sectional imaging with the CT scanner, you can also see it. So great imaging tests. When we look at the musculoskeletal system, which is the most visible thing externally, people have a certain facial structure. They have long fingers. They have a long, narrow thoracic cage, and sometimes with a pectus deformity or a dip in the breastbone. They can have more stretch marks than usual. They often have very flat feet, and they can even have changes in the structure of the spine that you can recognize on imaging. So I'm going to turn the discussion over to Dr. Deyle, and he's going to talk to us about genetics and genetic testing.
So, just to give you some basics about genetics, I always tell my patients, for better or for worse, you're half your mom, half your dad. Some people find that okay, not so okay. But our genetic material comes in two. So we get 2 copies of each gene, one from mom, one from dad. They come on these things called chromosomes, or inner cells. We have a total of 46 chromosomes. They're paired up, 2 1s, 2 2s, all the way to 22. The last pair are X and Y. XX your female, XY your male. When the DNA is on these chromosomes, it's coiled up, and you can read these sequences that are in these coils. And there's 4 letters, A, T, G, and C. The only 4 letters make us who we are, and how they're put together make up genes or other parts of DNA. So this is just a schematic of what a chromosome looks like, and this would be a nucleotide pair. These are just the letters that we read, or that the cells read too, also to make stuff. So there's portions of the DNA that make stuff, portions that don't make stuff. When it makes stuff, it makes a protein, and that is what makes us who we are. Every part of our body is made of proteins. So Marfan syndrome is a genetic disorder. It's caused by changes in the fibrillin-1 gene, or FBN1 gene. And since it's a dominant disorder, you only need one change in one of the genes to see an effect. Now, the effect can vary from person to person, but if you have this gene, you will probably have some manifestations of Marfan syndrome. And this is just a family tree showing what it looks like in a dominant disorder, where all of the colored individuals have the disease. So how does a change happen, and what is a change? A change in the DNA is a mutation, and a mutation is what causes an alteration of the gene that causes alteration of the subsequent protein that's being made. And this is just a schematic of that. Now, we do genetic testing to verify that patients have Marfan syndrome. So to make the genetic diagnosis, or actually the diagnosis of Marfan syndrome, patients need to have first, well, this is for patients who don't have a family history of Marfan syndrome. So first you need aortic root dilatation, and then you need to have either a systemic score or physical features that add up to enough scores. They have to have 7 or more of these scoring points. Or you have to have lens dislocation, which you talked about, or you have to have a change in the fibrillin-1 gene that leads to Marfan syndrome. So now, if there is a family history of Marfan syndrome to make the diagnosis, you either have to have aortic root dilatation, or a systemic score of 7 or higher, or lens dislocation, or fibrillin-1 mutation. So it all changes depending on if there's a family history. But when we do genetic testing, you can have a number of 3 different things. I always like to say it is yes, no, or I don't know. Yes means you have a positive change or mutation that has been identified that leads to Marfan syndrome. Negative mutation, or negative test where there's no mutation was identified. Or a very uncertain significance, which we really don't know what that means. So when that happens, sometimes we will do family testing to find out if other individuals in the family carry the same gene and if they're affected with Marfan syndrome or not. Kind of gives us an idea. Or if we look at some of the predictive markers or predictive algorithms when we do these things through these different protocols, if it looks like it doesn't mean anything, we usually say that. So it can have three possible outcomes from genetic testing. So the benefits of genetic testing are to verify the diagnosis, because there are a number of other genetic disorders that kind of have similar physical findings as Marfan syndrome, and also to personalize the care to that patient. The limitations are that our technology doesn't pick up every change, because it only looks at the regions of the genome that actually make stuff. So if it's on the part that doesn't make stuff, we may not find it. So that's some of the limitations of genetic testing at this point. When I see a patient in Marfan Clinic for genetics, I come as a team, not only me, but also with one of my genetic counselors. And that individual takes a really detailed family history, helps with pre-authorization of genetic testing, also with the benefits. That person will also discuss risk and benefits of testing and help interpret tests and provide psychosocial support for patients who come into our clinic. And with that, I will turn it over to Dr. Bowen again.
Well, I really appreciate that discussion, and I want to emphasize to the audience that it can sound very complicated, and there are some complexities in this. Now, fortunately, the diagnostic criteria, we don't even have to memorize them. They can get a little involved. They are in the Marfan website that I showed you earlier. Also, it's interesting to hear that the genetic testing is not always black and white. There can be some in-between answers. And this is really why we use a genetic specialist and also a trained genetics counselor to help us interpret these tests. This is a very necessary specialty. It would be possible, for example, for a general doctor to order the testing, but we really don't have the knowledge in depth of medical genetics, and you really do need a genetics specialist on your team. Now, talking about the team, you can already tell that the Marfan patient needs care in different specialties, and our clinic provides this with various specialties depending on the body system. And of course, the cardiology aspects of it and the cardiac surgery are important because those are the dangerous things, but other aspects are very important as well. Now, what about the treatment of the Marfan syndrome? There are some personal behaviors that are important. When you have an enlarged aorta, you have to take some responsibility in the treatment by avoiding stress and injury to your aorta. There are some guidelines with physical activity, for example, and the person should not participate in very heavy or strenuous physical activities. You want to protect the aorta from impact. There are some medications that we'll discuss, and Dr. Pochettino will help us with the surgical treatment. I really want to emphasize that in this new era of better science and understanding of the Marfan syndrome, the original concept that these were structures and that if you had a weak structure, that was it, and that couldn't be modified, a little bit pessimistic. But now we understand through 30 years of Marfan research that this important protein also regulates a signaling pathway that actually changes the structure and the function of cells in a modifiable way, so that an overactive signaling pathway potentially can be modified, and that some of these changes might be prevented or modified. Now, this was tested by Dr. Dietz's team in the mouse, and just to show you some illustrations of a normal mouse with a small aorta and a normal structure with a microscope, but the mouse that has the Marfan mutation has an enlarged aorta, and you can see that it's an abnormal wall where the elastic fibers have been broken down. Now, this is a mouse treated with a beta blocker, and this is a mouse treated with very high doses of losartan. And so with the losartan treatment, the mouse really, the tissues respond very well, and they really don't develop serious Marfan changes. So how does that translate? So we know in the mouse, the aorta develops normally. What about in people? Well, we've had beta blockers for some time, and the beta blockers do work by reducing stress on the aorta. They do have benefit. in reducing aortic enlargement. The new angiotensin receptor blockers have now been studied in a number of human trials, including in the United States, and they have been found to reduce TGF-beta signaling and also provide benefit in slowing down the enlargement of the aorta. So we now have two tools for medical treatment. So now I'm going to turn the discussion over to Dr. Pochettino, and he's going to talk to us about the surgical treatment.
So over the years, Marfan syndrome obviously affects the entire body, but it causes death when the aorta falls apart. I mean, so that while the spine and the other abnormality can be very debilitating and indeed need to be addressed, one of the calls that we are asked to intervene upon is to prevent dissection. Ultimately, dissection is what happens to the aorta. We saw some pictures earlier of the middle of the aorta, the media, we call it, using a Latin term. And that's where the abnormality exists, and that's where the disease of dissection occurs, within the middle layer of the aorta. When that disrupts, it leads to death if it's not treated emergently, and even if treated emergently, once you've had a dissection, your life expectancy is short. So the key is prevention. So how do we look at the aorta? We talked about the issue of imaging the aorta. First of all, we image with echocardiogram, we image with CT scan, and when the aorta reaches a certain size, which typically we think of in an adult 45 to 50 millimeters, that's the time when we need to consider intervention again as a prevention of dissection. The intervention ultimately involves replacement of the aortic root. The aortic root being that part of the aorta that contains the aortic valves, and it is most affected by the Marfan syndrome. Now, over the years, the American College of Cardiology, the Surgical Society have looked at criteria, and it has become clear size is the thing that we can look at and allows us to make a rational decision, although the quality of the aorta is something we cannot look by CT scan and by ultrasound, and that's something that we would like to know more about, and there's more investigation in the future. However, size we can read. This is an angiogram that looks at the aortic root. That's a classic look of the Marfan aorta. You'll also see some dye in the ventricle. This patient has also aortic valve leakage, so insufficiency also known. These are the general criteria for intervention, and we talked about in the Marfan population, 4.5 centimeters become the accepted size at which we need to do something. This is the standard Bentall operation in a graphic form. What it involved is detaching the coronaries, getting rid of the aortic valve, and getting rid of the entire ascending aorta, where 85% of all dissection occur in this section of the aorta. By removing it, that's where the risk is gone from that process. Now, if a patient, for whatever reason, does not wish to have a mechanical valve, the classic Bentall involves placement of a mechanical valve as a replacement of the aortic valve. We can place a tissue valve. Tissue valves are animal tissue. Any natural tissue will have a limited lifespan, and in general, we think of a tissue valve lasting 10 to 15 years. However, over the last decade or so, one of the advances in surgical treatment in Marfan specifically has been retention of the aortic valve. What's called valve-sparing aortic root reconstruction. It's a big mouthful, but essentially the valve is not thrown in the bucket, but is kept in place if the valve is normal. Over the last decade or so, when this has been used, there have been very, very encouraging results. That is to say, the aortic valve continues to work well, and the aorta is gone, so that that risk of dissection is gone, with the benefit that the patient keeps his own aorta, the aortic valve. Now, I just wanted to put this, not to scare anybody, but to just show that the relationship of the aortic valve and the aortic root are not simple-minded. So when we as surgeons are asked to reconstruct this, there are certain things that we have to keep in mind, and they're not something we can improvise. This is just graphically an illustration that shows how the operation is done. The aorta is transected. You're looking down at the aortic valve from the top. You detach, this is the right coronary, this is the left coronary, they're detached. The valve is retained, so that's what you're left when everything has been taken apart. And then you have to make some measurement. You saw that schematics showing the relationship of the aortic valve, the aortic leaflets, and the root, and a relationship is found based on what we have to work with. And then based on that, we select a graft, certain size, certain characteristics of the graft have to be implanted, and this is what you get at the end. So the graft is implanted at the basic beginning of the aorta. We call that aortoventricular junction. That would be this line. And then the aortic valve is re-implanted within that dacron graft. And of course, the coronaries are put back where they belong when the operation is done. This is what it looks like surgery. So these are what you're looking down is that aortic valve that is retained. This is the right coronary. This is the left coronary. And when the valve is reinserted inside the dacron graft, that's what it looks like. It looks like a beautiful valve inside a dacron graft that will probably do very well with this patient for many years to come. And the coronaries are reattached to complete the operation. So this is what we do as a prevention. The aortic valve is not the problem, the aorta is a problem. So we get rid of the aorta, we keep the aortic valve, and then the patient is followed forward, looking at the rest of the aorta. Of course, 85% of the problem has been taken away. The rest of the aorta is still there.
I guess I want to say one more thing about genetics, and it kind of goes towards what you do in the repair side of things. There have been a number of families who have been diagnosed clinically with Marfan syndrome in the past, and this is just I want to say a plug for myself, but you know, it shows the utility of genetic testing. Is that in the last 10 years, there have been a number of new genetic disorders that have been identified that are very similar to Marfan syndrome with different characteristics as far as from the genetic standpoint, but they look like Marfan syndrome, and then they have aortic dilatation and aneurysms and all these things. And I think it's important that when you guys do your repair, you know what you're dealing with, because some of these that mimic Marfan syndrome may not be. So I've seen a lot of patients in Marfan clinic, and even my own clinic, where they've said, oh, my family all has Marfan syndrome. We were diagnosed 30 years ago before the advent of genetic testing. In reality, they have something different. I think there's always a need for having that information for the family, and then it helps out future treatment options.
And I'm really glad you brought that up, because this gets to the concept of the Marfan-related disorders. Mm-hmm. And I know when I started seeing Marfan patients, the fibrillin gene had not been identified yet, and we were working a lot with the physical appearance of the person. But today, as you said, what's called a Marfanoid body type, in some cases is the Marfan syndrome, and it is a fibrillin mutation, but in other cases there might be other components of the connective tissue that are affected, and it's not fibrillin. And as you already said, they may have a different natural history. What we mean by natural history is these aortic emergencies might occur earlier in some of these diseases. So this whole field of related disorders is now there, and a Marfanoid appearing person might not have the Marfan syndrome. And I guess this is another reason that another way to say this is that we're now in the era where genetic testing has taken a bigger and bigger role. When we could only test for a few genes, we could know if the patient, for example, had a fibrillin mutation. But now we have additional tests. And for example, if we want to test a Marfanoid person with a bigger array of genetic tests, how many can we test for today? How many aneurysm genes are there?
On the current panel, there's about 20, 25, depending on the panel.
Okay.
And some of them are specific to Marfan syndrome and related disorders. Some are little add-ons, but for like Loeys-Dietz syndrome, which is a related disorder, there's now 5 different genes that lead to it, plus Marfan syndrome, plus a whole bunch of other ones in other disorders. So you're looking at about 20 genes now.
So I guess, if I were to wrap up the discussion we've just had, the Marfan syndrome is an important disorder of connective tissue. There is a set of criteria for making the diagnosis, which are read. You can read them on the Marfan website. It's best done in a team approach with a knowledgeable person that understands the cardiovascular aspects of it, plus the other aspects. Consultation with a medical geneticist. discussion with the experienced Marfan surgeon for when the patient is going to require an operation. And if I had to say what is the number one goal of care, I think the number one goal of care is to protect the aorta until that patient can be taken safely to the operating room for a preventive aortic operation, avoiding aortic emergencies. And then once that is accomplished, then that Marfan patient will typically lead a very long life and will have other conditions to deal with, of course, because the operation will take care of the aortic problem, but there will still be the problem with the eyes, the musculoskeletal system, and our Marfan patients and their families are very interested in quality of life and the disability. So here's the first question. I'm 26 years old and recently diagnosed with Marfan syndrome. Is it possible that I can have children? So that sounds like that might be a good Dr. Deyle question.
So the answer is yes. People who have Marfan syndrome have children. I guess I don't know if that's a male or female.
Yeah. Does it make a difference?
Yeah, well, it does. Females have more risks because of pregnancy. It depends if they've had their aortas repaired or not. And that kind of increases the risk if it hasn't been repaired. Because the immediate time right after delivery is usually when patients have the greatest risk of dissection in pregnancy. So if it's been repaired by a thoracic surgeon, right, then it changes some of the risks, but you can still have kids.
So it sounds like the general answer is yes, but there are some nuances here, and talk to your Marfan doctors about it. Now, here's another question. What are some of the signs of Marfan syndrome that may be harder to detect? And I think I would say that the more obvious signs are the musculoskeletal ones. It does require an eye specialist to recognize some of the more subtle eye changes. And of course, an experienced cardiovascular person needs to be in charge of the cardiovascular imaging and the cardiovascular diagnosis. So yes, there can be some signs that are hard to detect. That spine change that I showed you, for example, has to be identified on an MRI or a CT. Now, if none of my family members have Marfan, why did I get it? And again, Dr. Deyle, how can that happen?
Well, you can always be the first person in the family to have Marfan syndrome. Our cells are really good at correcting errors in our DNA, but 1 in every 1 million base pairs, there's an error. And if we have 3 billion base pairs, you tend to have a fair number of errors. Many times these happen in genes or spaces that don't really matter much. But sometimes you can be the first one to have a change in the Marfan gene.
Okay. Now, here's an interesting question. How often do you recommend a 73-year-old with an aneurysm in the ascending aorta to be scanned, and what type of scan is preferable? First of all, I would say that it matters a lot what the diagnosis is. That 73-year-old could be a Marfan patient with a relatively mild aortic disease where they have survived that long without repair. But probably that patient does not have the Marfan syndrome. And I think the best way to determine the frequency of scanning is to talk to your experienced cardiovascular person about it, because it does depend on the diagnosis. As a general rule, probably most of our patients get annual scanning, but it does depend on the individual situation. Sometimes it's done more frequently. Here's an important question about medications. What medication do you recommend for a Marfan patient with a slightly enlarged aorta? And the good news here is that we now have 2 medications that have been shown to work. Beta blockers work, and so do angiotensin receptor blockers. Primarily losartan is the one that has been tested. So again, a good opportunity for you to talk to your Marfan doctor, and you can choose together with your doctor which one of these 2, or sometimes a combination, might be considered for your special circumstances. Here's another question. Where can I find a doctor who can diagnose Marfan syndrome? And there are now enough institutions with a lot of experience and expertise in the Marfan syndrome. And again, I would refer you to the Marfan website or the Marfan Foundation, and they even have 800 telephone numbers, and you can find out where the experienced institutions are in your region of the country. They are all over the United States. Now here's a question for Dr. Pochettino. There is a heart surgeon in my community. Can I have my operation done at home, or do I need to come to Mayo or another large institution like Mayo?
That's a typical question, I would say. I mean, the issue there is both the infrastructure of the institution as well as the frequency with which the given operation is performed. And valve-sparing root replacement specifically is still an operation that is not performed that often in most institutions. And I think like anything else in life, if you do something very commonly, very frequently, you're going to be good at it. And a large institution that sees a lot of Marfan patients, that performs a lot of such operation, is going to generally be better than somebody who may see once or twice an aortic root aneurysm in a Marfan patient that would perform that operation rarely. So I would say that's a general trend. As to any one specific surgeon, it's hard to, obviously, to speak in specifics. But I would say if you have an aortic root aneurysm and have Marfan or Marfan-related syndrome, one of the questions is how often is this operation performed at the institution, and how often is the operation performed by that given surgeon? That answer is a starting point. Beyond that, I mean, clearly I have an interest in that operation, and we certainly have a team here that we can provide that support. And there are other places as well, but that is an important question.
Okay. So here's another question. Now this gets to the ability to do physical activity. My daughter is 12 years old and was just diagnosed. Can she still participate in sports and activities with her friends? And these are difficult issues for young people because, of course, they want to be on sports teams. They want to be active socially with their friends, recreationally, and yet there are risks. So I think the general rule would be to not do very strenuous activity, to protect the aorta from impact. Now, within those limits, what specific activity is okay and what specific activity is not okay. So I would say, a very competitive contact sport is definitely not okay. But in between, what particular activity might be socially and recreationally important for your child, talk to your doctor about that. But those would be the general guidelines. But yes, we don't want people to be physically inactive. They can certainly have a reasonable level of physical activity. Okay, now here's another Dr. Deyle question. This comes up all the time. What should I do if my insurance won't cover genetic testing? And how much does it cost? How expensive was it a few years ago relative to today? Those practical questions.
Well, a lot of places try to pre-authorize the genetic testing to see if your insurance will cover it. You can always call your insurance company to find out if they will cover it. The cost of just that gene alone, reading the letters plus looking to see if there are loss or gain of genetic material, somewhere around $1,000 to $2,000. Now, when you do the entire panel to look and see about other related disorders, you're looking at between $5,000 and $6,000. So it's not a cheap test. But the best way is to contact your insurance company to find out if they'll cover it.
So what if a problem gene is identified in one family member? Do other family members, can they be tested more cheaply, or is it still a very expensive test?
Well, when you find a change, it's really cheap. Comparatively speaking, it's a couple $100.
A few $100, because then you can go look for that specific
Just look for
mutation.
that one spot, and that's all we're looking for.
All right. Okay. Now this is, I think, another probably surgical question. So if a patient has a pectus excavatum, well, the question is, how does that factor into the risk of aortic dissection? And I would say it's a separate issue. The pectus is important, but it doesn't relate to aortic dissection risk. But for Dr. Pochettino, when do you decide if the pectus is severe enough to require surgical repair?
No. Pectus excavatus specifically is unfortunately a relatively controversial topic in terms of when to repair. And one of the unfortunately driving issue is that it's been over the years difficult to document a objective problem that arises from that. The most common objective problem that we test for is pulmonary function test. When you have pectus, the lower portion of the sternum typically is indented. It displaces the heart to some degree, which makes repair of the root somewhat more challenging. And because of displacement of the heart, the lungs are compressed in some fashion. The diaphragm doesn't quite work the same way. Often patients also have additionally some scoliosis, so that the entire chest cavity is inappropriately put together and the function may be lower. On the other hand, a young individual can compensate for that skeletal abnormality, so to document enough of it decreasing pulmonary function test has been the challenge. And a lot of insurance will want a clear-cut documentation of decreased pulmonary function test before they can authorize payment. And that has been a headache for surgeons, has been a headache for patients, because while you can not feel completely normal when you do some activity, it's hard to prove. And I would, there are different things that have been defined in terms of ratio of how close the sternum is to the back of the spine. There are criteria as a surgeon that we look for when it would be appropriate to intervene. But the insurance world is interested more in functional rather than anatomic details, and they will agree to cover it when the functional abnormality is documented. That has been somewhat of a difficult source.
Okay.
Does a pectus ever come into play when you're doing repair?
One of the issues with pectus is if the patient has a deep pectus and has a borderline aortic aneurysmal dilatation, say 4.3 centimeter root and a deep pectus, and which one do you do first? That's been a common issue. It is usually not a good idea to do it at the same time. The complexity of the root reconstruction makes it so that when you're done with the root, the last thing you want to do is to start working with the bony structures. And we typically individualize. The answer may be kind of a cop-out, but the answer is that it depends on the age of the patient. It depends how the aortic root has been followed. We like to give precedence to the aortic root because that's a more deadly issue if we miss. But we keep in mind the fact that if the aortic root has been borderline for a while and the pectus is more causing trouble than the root, then maybe we should take care of the pectus and follow the root and then intervene on, one does not completely negate the other. So we can have a patient who has had the pectus bar are used often. One of the issues, can you do it, aortic operation, if you have the bar, you remove the bar, you do the aortic operation, you put the bar back in. So that does not exclude. So the two are not exclusive of each other. We try to coordinate so that we don't have, issues.
It's interesting when you first hear the question, it seems like there may be a black and white simple answer, but what I'm realizing from a lot of these questions is that the answer is get an experienced team and discuss it in depth at your consultations. Now, if I were a patient needing an aortic preventive repair, I would want to know, can you tell from my imaging if you can preserve my valve, or do you have to wait until you get into the operating room and actually look and touch the valve before you know?
Well, that's the ultimate question that every patient will ask when they come with this problem. And the answer is that 90% of the information is available for me from the preoperative testing. Preoperative testing being CT scan or MRI and echocardiogram. However, there is that 10% of uncertainty that no matter how many tests we do, we just don't get all of the information. And those uncertainties relate to the leaflet quality. And one of the things that is very hard to see on echo or on CT scan is called fenestrations. Those are very, very small tears that occur in the Marfan leaflets, especially when the aortic aneurysm has been long-standing, which is one of the issues sometimes we like to intervene earlier rather than later, because the longer an aneurysm is allowed to remain in place, the more likely those little tears, again, fenestration, fenestra means window in Latin, so there are little tear that occurs in the leaflet. The more fenestration, the more tears, the more unlikely this valve will be to last the patient's life. And therefore, there is an issue of, is it worth doing it if the valve is going to fail soon? So that's a 10% where I cannot know that until I get there. But most of the information is available. So that's why when I talk to a patient about this operation, I would say 90% of the information is available and allows me to make a decision. That 10%, I have to be there to complete the decision making.
Okay. Now here's a great question, again for Dr. Deyle. My daughter has dislocation of lenses, and we have gone through testing, including genetic testing, to see if it is related to Marfan syndrome. Cardiology came back negative. She has no issues for now. However, her FBN1 gene came back as a variant. As her parents, we did the blood work, and we do not carry it. She is a healthy girl, but based on what we know by now, do you think this is related to Marfan syndrome or a related disorder, another syndrome?
Well, so there are very few things that cause lens dislocation. One of them is homocystinuria, and the other is Marfan syndrome. So whenever we see lens dislocation along with FBN1 variants, it increases our suspicion that this is probably a pathogenic variant. Now, if I was a patient's physician, I would monitor them as if they had Marfan syndrome, given the lens dislocation, the variant, just to be sure. Just because, like I said, lens dislocation doesn't happen many things. So there are other. I will also say that there's a lot of variation in patients, individual patients with changes in the fibroin1 gene. There are patients who don't have any aortic root dilatation but have a lot of musculoskeletal manifestations. There are people who have changes who have just the aortic changes but none of the physical manifestations. So I think as far as genetic testing goes, we are still trying to figure out what each one of these changes mean, given now that we're doing all this testing on every patient. Before it was, as you said before, it was all based on clinical findings, and now we test everybody pretty much. And now we're trying to figure out what does each one of these changes mean. Does it always mean Marfan syndrome or something related to it? But lens dislocation usually with Marfan syndrome.
Okay, that's an important point. Now here's another great question. What research is being conducted on Marfan syndrome? And what I would say, remember we talked about the different eras, the earlier era, but now the era of technology and science. And one of the important tools for understanding a disease is the development of an animal model. And for many years there was no animal model of the Marfan syndrome, but now with a mouse model, a lot of medications can be tested, and also the basic biology can be studied further. So there are mouse laboratories which are very actively studying not just the Marfan mechanisms but related ones. Also, I said that we have some early human trials showing the value of these new drugs. But for example, do we know which of the angiotensin receptor blockers is the best one to use? Do we really know the dose? Do we really know at what age the medication should be started? And all these are questions that are under active study, and over the next decade or so I think we'll be seeing more answers to those kinds of questions. And I would say that right now, we have reasonable medical therapy, but the goal in this condition is to have a systematic, personalized care plan primarily designed to protect the aorta with personal health behaviors, with medications, with periodic monitoring that you'll determine the frequency with your doctor, and then get that patient into the operating room at the appropriate time for a preventive aortic repair, because most Marfan patients will need one during their lifetime. And then after that is over, then deal with other things that are extremely important, but the life-saving thing to do is to protect that aorta and get it repaired at the appropriate time. So that would be an answer on research and medications. Where can I find more information on Marfan syndrome? And again, I would refer you to the Marfan Foundation website. Now there are more questions coming in. Can you talk about normal growth and BMI assessment for Marfan patients? I am a dietitian who has seen some underweight Marfan patients. So, Dr. Deyle, can you say a little bit about normal growth in the Marfan population?
Well, they tend to be taller. They tend to be taller individuals. But like I said, as we're seeing more and more patients with Marfan syndrome, they don't always fit the classic description of Marfan syndrome, always being tall and long arms and long legs. So most of my patients, I mean, they're usually thin, but I don't ever see them way too thin. I haven't seen many with problems with growth, actually.
So they generally don't have. Yeah, and I would say, you know, my experience has been generally slender, but as people have now survived into their adult years because of successful surgical treatment, now there is a problem in the middle-aged Marfan patient that is beginning to emerge of the central obesity that many of them get. So it's clear that, again, this gets to the research, there are metabolic problems in the Marfan syndrome that were not apparent until the patients began to survive. And now those will eventually be studied to a greater degree.
One of the issues that, to some degree, due to the success of prevention of dissection, is that we are seeing older Marfan patients. Mm-hmm. There are a lot of questions that have been unanswered just because the lifespan 30 years ago of a Marfan was not going to be very long. And one of the things that always comes up, you know, if the aorta does not misbehave and it's appropriately treated or replaced as needed, what's the normal lifespan of a Marfan patient? And my general approach is that it should be relatively normal. Mm-hmm. That the rest of their systems, while they can cause some disability in some individuals, they're not life-threatening, most of them, and they can be managed, and the patient should expect to live a normal lifespan if the aorta is protected or replaced as appropriate.
That's an important point. Well, let me ask you this question. Let's say that you have the Marfan syndrome and you're being watched, but you know there is some risk of aortic dissection. We should emphasize that our tools for identifying people when they should have surgery are very good, but they're not perfect. So if you are having a dissection, how do you know it? What does a dissection feel like to the patient?
To most patients who have had a dissection, they can tell you the minute that a dissection occurred. It's usually not a subtle finding. It is usually a rapid onset chest and back pain. And unlike other diseases, it's a sort of thing that is very memorable. Those that survive, they will tell you where they were, what they were doing, what time it was, and everything else about that moment that it occurs. So it is not subtle. Chest, back pain, the patient should seek medical attention immediately. There is a significant upfront chance of the aorta falling apart, so there's a mortality upfront. And once the patient gets to an appropriate institution that can deal with the emergent surgery, there is anywhere between 10 and 20% risk of dying from the intervention once that occurs. As far as we can tell, once you survive that, most Marfan will require all of the aorta replaced over time, because the dissected Marfan aorta will continue to dilate. You typically replace the ascending part emergently, do basically the operation we talked about, but done it emergently, which is never quite as good as when you do it electively. And then you follow the rest of the aorta, and in the Marfan patient, the rest of the aorta will require replacement, which is certainly a lot of surgery, and all else being equal, that's where your lifespan is reduced, at least by 10 years, you know, if you have had a dissection. Again, a lot of this data is retrospective. It's hard to know as we get better at our treatment of aortic disease whether that number is faster, but it certainly it changes the ballgame, and avoidance is the key.
This gets me, I meant to make this point earlier, but let's talk about it now for a minute. One interesting thing to think about is, you know, have all the children and young people with the Marfan syndrome in the United States been identified? And of course they haven't. So there are people out there who have the Marfan syndrome and the diagnosis has not been made yet. So sometimes the question, it's very interesting to see patients as they come into the clinic, because sometimes they have been sent by a teacher who made the first observation, a coach, sometimes it's the eye doctor, or they were seen for an orthopedic problem. So I think getting to the point that you made about the appearance, I would say the very tall person who's very gangly, who has a significant pectus, or who has scoliosis, and who is very, very nearsighted, not just a little bit of nearsightedness, but a high degree of nearsightedness. And if that child can be identified by anybody, by the coach, by the dentist, by the teacher, then that child should be tested and should be seen in a setting where they're familiar with the Marfan syndrome. A related part of this is, what if that child is Asian, Hispanic, African American? And I would say that the literature in this field is not as complete today as it will be in the future, and that at least in Hispanic and Asian groups, the external changes indicating the Marfan syndrome might not be as obvious. There are some studies that show that. So diagnosis is not always easy, but those would be the features to look for and to refer for. Let's see, any other questions from our group? When will the aortic enlargement show, and at what age does it start to show? So as a geneticist, you talked about variability.
Yep.
When in development will the aorta start to show changes?
Well, you can actually have individuals with dilated aortas even shortly after birth. So it can happen at any time. Usually the most rapid expansion of the aorta is during growth, so puberty. But it can happen any time, and if there's a family history, we say that everybody should be evaluated as soon as possible.
I think that's an important point too, and you know, we just didn't have time to talk about all the nuances of the biology, but some mutations are mild, some mutations are moderate, and some are very severe. And if the child is born with a very severe mutation, then they'll have problems even at birth or shortly after. Well, we have more great questions, and we are just at the place where we really do have to begin to wrap up our discussion, at least for the time that we have right now. Now, I do encourage you to submit additional questions, or if we didn't get to your question, please submit your question. We will continue to communicate and dialogue with you even after the conclusion of the program. But as far as our time today, our Marfan team, you know, we're the three people who are here today, but we have other clinicians, we have cardiologists, we have nurses. I think it's very important to acknowledge other expert fields. When you talked about institutions that have experience, another huge part of this is the imaging specialists. We have vascular radiologists, for example, so that on behalf of all of those members of the Marfan team here, not just the three who are here today, I want to thank you for your interest, for your participation, and we will look forward to your additional questions. So thanks again.